Okay, welcome back. Welcome again. Nice to see you still here. Welcome to the Enhancing Clinical Practice and Outcomes stream of SNOMED CT Expo 2024. This is our third session this morning. My name is Rory Davidson. I'm the Chief Digital Information Officer at SNOMED International, and I'll be moderating today's session. All questions will be answered at the end of the presentation. Online attendees, please put in your questions during the presentation. We'll bring them up afterwards. And in the room, please raise your hand and we'll give you a microphone. With that, I'm very pleased to introduce Leilei Zhu from University College London Hospitals, who will be presenting Enhancing Clinical Documentation with MiADE Natural Language Processing System in a Leading EHR. Over to you.
Thank you very much. In the past 6 years, I have been working with my colleagues in UCLH and led the data standards implementation in one of the major electronic health record systems called EPIC. I don't know how many of you have heard of EPIC. It's an American EHR system. But this presentation is kind of like the sequel to the one I did last year in Atlanta. At that time, we were just about to start the study. So I omitted a lot of the background information because I thought people probably already know them. But I think I made a mistake because it's a different audience today. So I'm going to be adding some of the background information as I talk. Has anybody heard of my hospital, UCLH? If you haven't heard of the hospital, you probably have heard of a university called UCL, which is a world-class university called University College London. The hospital is affiliated to the university. I think the hospital is actually quite famous and situated in central London, and it provided secondary and tertiary care. One of the major things about the hospital is we are one of the 7 biomedical research centers within London. There are in total 20. The Biomedical Research Center is established to accelerate the academic achievement on the clinical practice level. This study or this project kind of a product of that. My colleague Anthony, in his presentation, he talked about he briefly mentioned about MiADE. So this project is called MiADE, and he also briefly mentioned MedCAT, and we will talk it through. My hospital started the EPIC implementation 6 years ago. So we are now 6 years into post-implementation. When we implemented EPR, we thought that we probably very naively thought that EPIC is going to give us all the structured and standardized data, and my clinicians would. We know it's a challenge, but we thought that they would still embrace the structured data input. But the reality often far from the truth. So getting my clinicians who record structured information in the little pockets on each screen has constantly been a challenge. So it's from that we thought about other ways how to encourage documentation, right? And we also did some internal audit to show how bad or how well our structured data is recorded. Using diagnosis as an example. Sorry. Right. During pandemic, we found out that 62% of the diagnosis, only 62% diagnosis is recorded on the problem list. So you have 40% of the records that doesn't have a diagnosis recorded on EPIC. Our clinical audit also shows that only half of a clinical coded primary diagnosis in the internal medicine specialty, and in an outpatient setting, you hardly get any diagnosis recorded at all in a clinic. So we thought about natural language processing because we still feel that using natural language feels more natural, to clinicians. But most of the natural language processing is doing retrospective NLP study. You have a large amount of information, you extract them, and you apply the NLP tool, and you get your structured data, and then you use your structured data to do secondary care service purpose, right? Operational reporting or research. But anybody who interact or using electronic health record, or anybody who works in a clinical setting, has a clinical background, would know that a lot of the times care requires instant data input. And if there is a delay, sometimes it doesn't really reap what you wanted to. So what we do is we thought maybe we can think about how to use NLP tool to directly feed into patient care, because that's, by the end of the day, that's what you buy a very expensive electronic records for, to support direct care. So what we thought that we're going to add one more thing into this. And apart from all the NLP extraction, and we thought maybe we need a way to feed back those structured data that's generated by the NLP back into the electronic record system, hopefully without any delay. So then we came out with this MiADE project, and it's actually funded by NIHR, National Institute for Health Research. At that time, they had, it's about 3 years ago, they had an artificial intelligence or AI grant. We won the grant money, and then we continuously to try to get funding to support the project. It's a collaborative project between the university and the hospital, and also a children's hospital down the road called Great Ormond Street Hospital, because our patients transfer back and forth, and when they grow older, and then they go to our hospital. And also Great Ormond Street also uses Epic. We started a clinical evaluation. So the tool is already being used now in the clinical setting, but it just hasn't implemented trust-wide. We selected a small group of volunteers, those clinicians volunteered. There were about 50 of clinical users said, I'm going to try this tool and feedback to you how we feel about this tool. But the next plan is to get more funding, implement it in a bigger scale, and hopefully do a trust-wide implementation. This is the fundamental part of the end-to-end process of our MiADE project and all tool. So there are 3 elements, key elements. One is Note Reader. Note Reader is an Epic tool. What Note Reader does in Epic is it extracts all the free text information, no matter how you free text it. You can, clinicians can type it, they can dictate it, but either way, it doesn't matter. Once you get free text information, you use the Note Reader tool, it will extract this information. But Note Reader tool is not going to give you the structured data or structured standardized data. So you need a second element. Sorry. So you need a second element, which is what my colleague Anthony touched, the NLP module or the NLP tool. We actually used, based on their great work, we actually leveraged the MedCAT NLP tool and used it in MiADE. So thank you very much. And then the third part is SNOMED CT or data standard. I didn't put SNOMED CT anywhere here. So, but where does it come into play? Those structured data or the clinical domains like diagnosis, medications, and allergies in Epic, we use SNOMED CT as the data standards, but we have different levels of implementation maturity. Some of the clinical domains are implemented more mature. When I say more mature, what I meant is my clinicians directly interact with SNOMED CT. We don't do any of the backend mapping, because as soon as they entered the term, it's already SNOMED CT. And then, but some is we have to require backend mapping, such as allergy. So this project try to cover 3 clinical areas, right? Diagnosis, medication, and allergies. But right now, we only manage to get diagnosis work on the shop floor. Because it takes a lot of effort and takes a lot of testing. And so medication allergies are going to be in the next pipeline. So you got that 3 bits, and then you get the transformed electrical health, you get transformed structured data, and it's feedback to Epic system. And then hopefully, we thought it's going to achieve point of care recording. This is getting to a little bit specific detail. This is how we use MedCAT or MiADE to annotate problems or the diagnosis. These are just some of the logics. We look at some headers, right? And we also write some of the bespoke logics, because during the implementation, we found that we do use the SNOMED CT synonyms, but we found some of the shorthand work, like shorthand handwritings that my clinician did, SNOMED CT, for the right reason, SNOMED CT content doesn't cover it for the right reason. So we have to manually write some of this logic and then go recognize this shorthand writing as this term. This is going to show, this is an interface of Epic and the problem list. And you can see the problem list is incomplete. I know it's incomplete because I've got more free text past medical history here than what has been entered. And the note reader button is on the right-hand side. You just need 1 click to activate it. It takes 1 second. And for my clinician, it takes 1 second. And then my clinicians started writing free text here. And then when they sign the notes, they go, 3 terms found for this patient. Would you like to, and then they can review the 3 terms, and then these are the 3 terms that pop up using the tool. And then they go, please edit. You have 3 places to edit. You can edit as a hospital problem or general problem or medical history. I go, I want to edit as a hospital problem. I edit, and it's form part of the structured data as patient records. This is a demo. I know, like, it seems to be really, really long, right? And then disjointed. But I'm gonna do a demo because it's actually happened really fast in a clinical setting. Because you don't want any delays. Any delays causing clinical practice, clinicians just completely don't buy it. And how am I going to do this? How do I get this demo to work? Yes, but I incorporated the video. Sorry. Thank you. Yeah, go. So clinicians started typing clinical notes, issues, past medical history section. Yeah. And then they go accept, send the notes, and they go, okay, there were 3 terms pop up. These are the structured ones pop up by prompt, and I go, I'm going to add those onto the problem list. And then I'm going to close the note reader. Generally speaking, and then now you can see that it's form part of the problem list recording. Generally speaking, they open note reader and they leave it all day until their clinic finishes. And so it happens actually quite fast. And okay, so I wanted to share with you some lessons learned and results found through our clinical evaluation study. In the previous slides, and I said there were 50 clinicians volunteered to be part of the pilot study and use note reader. But actually, in the end, there were 42 activate note reader. There were 8 who didn't do it. the pilot study started February 2024, so we are talking about 8 months now. But we had to go through a long drawing. In NHS, you have to do everything. The governance process takes very, very, very long, even to get the pilot study, because it's kind of implementing it in a real live system. Okay. I'm going to, the evaluation study's purpose is to establish how well or how bad the tool actually is for the front-end clinicians. To evaluate how well, our primary objective is, does MiADE allows more structured diagnosis in recording on the electronic health records, system? And if it does, how many against how many patients for a period of what time? And then the second objective, so the first one I would call it quantitative. The second one is more qualitative, is to evaluate the human factors in using the tool, right? The usability, the performance, and then the effects of the tool on the consultation process when the clinician conduct them and then the patient sits beside them. And then also we try to use the study to see, is there any improvements that can be made to make this product better? So the study timeline. The tool started, the pilot study started February, and then in 1 month's time, which is March, we collected feedback, met with the clinicians, and then go, how do you feel about it as an initial feeling? Is there anything we could do to improve it, right? And then their feedback and some of the data analytics that we derived feed into the second version and the third version of the MiADE tool. So feedback workshop, and 10 clinicians attended, and then they basically said kind of the things we already know, such as the tool prompts something that's absolutely irrelevant, or there are some errors like prompts to me, and or I don't want to add them. And then there are some clinicians who raise concern that problem list should be a very clean and a clear display of the major patient problems. Now you are basically focusing on adding things onto the problem. Are you not worried that the problem is going to be overpopulated with unrelevant information? Because the tool basically pop up everything that's structured. And then even it gets use the clinician's judgment to go, I'm going to add it or I'm not going to add it. Sometimes by habit, you just go, yeah, add. So that's a concern, a valid concern, that while you are worried about clinicians do not populate enough information on the structured data list, but actually it's not about the number or the volume of the information. It's not just about that. It's about the relevance there. There is no point populating information that's absolutely irrelevant. So there's a little bit balance there, but we haven't really grasped that perfect point for that balance. But I think it's a learning process for everybody here. Okay, so when they say the tool prompts to me some unuseful, useless information, what do we mean? These are the keywords that the NLP to pick up, and then these are the suggested SNOMED CT terms. These are actually useful ones, right? You got DVT, deep venous thrombosis. They are proper diagnosis. But if you look at the right-hand side, and then they pick up the word like happy, they prompt to say cheerful mood, right? Or upset, or feeling upset. They are actually not diagnosis. Some of them is actually kind of wrong, and it's, why do you pick up like the look at the term called drink and then prompt a SNOMED CT concept called, non-drinker. This is what I meant by version 2 and version 3 to make it better. One thing good about Epic is once your clinicians start using Epic in a data warehouse, it's faithfully created an audit trail. Basically, it tells you what has been prompted. Has this been selected by clinicians or not? Did they add it, or did they reject it, or did they just completely ignore it? So very rapidly after a week, we generated this analysis because we wanted to use the data to give a quick feedback to my data engineer or data scientist colleagues, and then started modify and improve the logic. Right. So how did we go? Right. What do we do? Sorry. I look at the data on October the 11th. There are a lot more data that really needs to be done. On the left-hand side is the quantitative, on the left-hand side is what I looked at in October, which is before this conference. The totally added diagnosis is 718 on 208 patients. And then there are majority of those diagnoses are added onto the problems, and visit diagnosis, which is a diagnosis in a clinical set used in an outpatient setting, is a lot less, 100 odd. Majority of those diagnoses are still happening in an outpatient setting. Even those users, they do mixed bag of clinic and the inpatient ward round work. I don't know whether it's because in an inpatient it's busier and in an outpatient clinic it's more discreet, and that's again yet to be found out. The interesting thing is I have slightly more rejected term than the accepted one, and but I'm not too worried because I look at the data here. This is what I did. I look at data in June. In June, can you see that we've got 3 times more rejected concepts than the ones that's recorded? And then this one, these 842 include the ones that's already structured on the problem list. And then the tool is just going to automatically reject at the back end. They don't even prompt this to create duplication. So in a way, I feel like it's making progress and it's making better progress, but there's still a lot of things that really to be done. Right. Qualitative results. Sorry, I wasn't the one who managed the qualitative results collection. So the information hasn't been collected, but we only got 11 out of 42 results, and the majority of them feels that it's very easy to use. You already saw it. It's a one click and it's pop up. It's generally kind of seamless. But still people complain about it got to be smarter. You know, we still have work to do to refine the tool. The future plans is senior buy-ins and, you know, trust-wide adoption and then collaborations. And also we have a GP project, which is an interoperability project that we wanted to automatically leverage the GP information and then using interoperability or FIRE automatically drop it into the secondary care or Epic records. If you think about it, that should really be the future way to go, because you already got the data recording in another system. Why do you repeatedly record it in a different one? I think, and this project this far, it may look like a minor one, but it takes a whole host of my colleagues' collaborative work and couple of years to get this far. And I think the value of this project is to show an academic tool and how well or not well used in a clinical setting. The major problem of EPR implementation is to get the data and the relevant, correct data, hopefully in the right format, but you are going to face a practical issue that the clinician just do not enter it. So I think like this tool is an example to show that we have to think more innovatively outside the box and then think about what we can do as health implementations to work with clinicians, creating tools to make their job easier so they can focus on clinical care. I think that's the end of my presentation. Yeah, thank you very much.
Thank you very much. Another fascinating presentation. We've probably got time for 1 or 2 questions in the room. If you have any questions online, please then put them in the Zoom app. Questions?
Thank you very much for your presentation. And I shouldn't be surprised because as the early slides talk about the record in the patient record, 50% not there. And I think 20 years ago, I was in NHS. I couldn't find the diagnosis code because people just write in the note. Yeah, so not much change. So, but back to the work you're really trying to achieve is to, as early presentation, you have identify the entity, basically diagnosis code, and that at the same time, at runtime, ask a clinician to pick the one they think is useful to be entered into the heading, into the right place, basically. That's from free text entry convert to the structured data. Yeah, and this actually I think was useful in a way. Is a kind of a validation about the note and entity recognition, because it's one key challenge. You can recognize quite a lot of code, like you list there, and also the feedback, and those are irrelevant.
That's right, yeah.
And I guess your next step maybe just filter out by the hierarchy of SNOMED CT, only focus on the clinical finding or even diseases as an output, and then reduce the code for clinician to select.
Yeah.
Yeah. Thank you.
Yeah.
Thank you very much. Very
That's
good
right.
presentation.
Thank you so much. Yeah, you're right. That's not a question. I was waiting for the question.
That wasn't a question.
You're right. And I'm really glad nothing has changed. And I think my statement to this would be why nothing has changed for 20 years. 20 years we were fighting the battle to get clinicians to record in a structured manner. 20 years later, we are still trying to fight the battle. A lot of times I go home and I ask myself the question, are we fighting the right battle? I think that's a question for everyone to have a think about.
Cool. Thank you very much.
Thank you.
With that, we'll close this particular session. Anybody online, please stay on for the next one. And anybody in the room, please stay in the room for the next one. So we'll be starting in